Welcome to our live webinar titled Autoimmune Disorders and MDS. Thank you for joining us today. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I'd like to recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda Oncology, and the generous support of our patients, families, and caregivers for supporting this webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection. If you are unable to view the webinar online, you can call in to hear the audio portion by using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you are finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I respectfully ask that you do 2 things to help me manage the incoming questions. Submit your entire question all at the same time. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Carlos Vigil, who is a clinical associate professor of internal medicine at the University of Iowa Hospitals and Clinics, Holden Comprehensive Cancer Center. Dr. Vigil will not be on camera today. He is in Iowa, where they've been hit very hard with storms, but he's joining us today by phone. So with that said, welcome, and thank you for joining us.
Thank you so much, Lee. This is Dr. Vigil from Iowa. Today's topic is going to be autoimmune disorders and myelodysplastic syndrome. The objectives are to learn about MDS and mechanisms of disease involving autoimmune disorders, to understand available options for treatment and clinic. My disclosures are on the next. So MDS encompasses a group of heterogeneous clonal hematopoietic stem cell malignancies, which are characterized, as you can see here in the diagrams, by several other components that interact with the myelodysplastic syndrome. It can involve from myeloproliferative neoplasias, acute myeloleukemia, Fanconi anemia, aplastic anemia, T large granular lymphocytic leukemia, and paroxysmal nocturnal hematuria. However, most of this is associated with defective hematopoiesis, with myelodysplasia and intramedullary apoptosis, which means, dead cells, an increased risk of progression to acute myeloleukemia happens, especially in the high-risk populations. In recent years, however, there have been a good approach, the next slide please, a good approach in trying to incorporate characteristics of molecular to try to define how the specific pathognomonic of MDS is going, to detect myelomalignancies a little bit earlier and try to prevent for healthy people to advance into MDS to AML. So we are going to be discussing a little bit the incorporation of these as well, and overall, we are going to be talking about immune system as well. So for introduction, I will say that, as I said correctly, heterogeneous process characterized by dysplasia on cellular agents. Please, the next slide. Ineffective hematopoiesis. Unfortunately, this is a cancer of the marrow cells, and there are several treatment approaches that have changed from the last year. newer applications are going to be reviewed. Next slide.
Dr. Vigil,
So
could you speak up a little bit?
Of course.
Thank you.
So one of the things is going to be that it encompasses neutropenia, anemia, thrombocytopenia, and dysplasia is part of the bone marrow characteristics of the MDS. In particularly, we are known, next slide, the characteristics of hypercellularity that is showing on the bone marrow. One of the things that is very important is to know about the prognosis, and one of the things that is very important is the cytopenias, the bone marrow blast and the concentration, the cytogenetics, and lately the molecular biomarkers that are going to be part of this. There is IPS score system who had been progressively getting better, but they're not involved in the molecular markers there yet. The next slide. And they are showing characteristics independently of the prognosis markers that we already described. I'm going to be showing a case that it will happen to have in our clinic in order to be a little bit more involved what it happens with the immune system itself. The case description, please. So there is a patient who happened to be 66-year-old, which is the characteristic age of presentation, unfortunately, of MDS, who has another comorbidity factors. We're talking about diabetes, hypertension, and the pancytopenia with general rash. He happened to have a white cell count of 2.4 with neutrophil of 1,500, hemoglobin of 8.9, and platelets of 84, with some rare circulating blast. Which happened is that he had erythematous and a skin lesion who was very typical, as we're going to be showing on the next slide, please. It was involving hands, and it was involving as well part of the superficial face. This skin biopsy was done, and it was showing mixed perivascular and histiocytic inflammation, and there was involved of the connective tissue, and it was reported as a dermatomyositis. As we know, this entity is an immune component, and there are several other who had been involved as well in the autoimmune diseases that it had been described previously. One of the most important ones, and I'm going to show, please, the next slide, is that despite the fact of having this inflammation, the patient was still showing hypercellular bone marrow with atypia and characteristics of MDS. There was such a little bit of connection with, in the molecular setting, characteristic of MDS with SRSF2 presence and AXL1 presence. And lately the patient underwent for a stem cell transplantation after receiving hypomethylation agents. With this and saying, it's very important to, in fact, to look into this and look into what is the characteristic of the MDS on this case. It was a low-risk disease. Yes, it was. And the other, it was the dermatomyositis that it was showing the presence of involving the skin. Dr. Kamraji, he described as well from Moffitt Cancer Center several years ago in patients who were having involvement of characteristics of the autoimmune disease. It was more prevalent hypothyroidism, some rheumatoid arthritis, psoriasis, inflammatory bowel disease, and vasculitis symptoms as the most common characteristics on the patients who were having MDS with autoimmune disease. Autoimmune disease is seen, and this is the next slide, where we're going to be talking about immunity. Autoimmune disease is very characteristic and involves, as I said, the thyroid, the skin, and it also encompasses as well the platelets in idiopathic thrombocytopenia purpura. One of the things that is more common in lower risk MDS, probably by the presence of interferon gamma R, TNFR1, and the tumor growth factor beta receptor that they interact and cause apoptosis of the cells. That's the reason why there is not such a proliferation, or I will say not a good proliferation of good cells. Is probably seen in 28% of the cases in lower risk diseases, mostly. And in higher risk disease, there is also some immunity, but it's going to be probably involved the DAMs or the presence of the autoimmune mitochondrial proteins. Is going to be involved as well proliferation of cytokine inflammation and tumor escape. So these are the characteristics that they are showing with the activation, especially of interferons and tumor necrosis factor and interleukins, that they're going to be expressing part of the characteristics in the next slide, that is involving, the next slide please, that is involving as well, as we can see here, DAMs and NOXAs and tumor toll-like receptors 1, 2, and 6. So one of the most important things that is happening with autoimmune disease is probably the activation of interleukins, and this activation of receptors either in the myelodysplastic or the MDS suppressor cell genes. Next slide. Next slide, please. And this is a complicated diagram that is showing several characteristics from Dr. Alan List, that they are involving and producing NOXA and ROS production by the activation of several pathways. Next slide, please. So we know, unfortunately, that the molecular markers are part of the characteristics. We know that there is IDH1, SF3B1, SRSF2, U2AF1, and others that have been described as, and other epigenetic factors as well that have been described as well in MDS, especially TET2, DMT3, and others. But the most important characteristic is that probably this signaling that we are seeing earlier with the immune modulator or the immune response is part that we are seeing later on the expression of these genes, especially the molecular that we are talking about. So there is still more evidence to show up or more to come. There is, as I said, probably 28% of cases that they are encompassing or doing together with the immunomodulation and MDS. And there is some treatments and alternatives that we can do on that part. Next slide, please. Here is the characteristic of the in adverse and favorable molecular markers. As we can see, S3B1, which is a very characteristic one for ring sideroblast MDS, is favorable. However, FLT3, TP53, and other ones, when they are evolving later on after the NOXA, after the immune system is impaired and gets evolving in proliferation, they can evolve into AML. So TP53, RANKS1, ECH2, PRPF8, and FLT3 and CBL are markers of worse prognosis. The next slide, please. One of the most important, it was by David Stinisman, doctor from Harvard, that he was mostly involved, and Dr. Rafa Bejar, who were involved in what is called, clonal hematopoiesis, earlier disease into catching up. There is some overlap from aplastic anemia and hypoplastic MDS, and several cytopenias had been referred, especially the presence of CHIP, ICOS, CICAS, and MDS had been able to be detected, and these are depending on the findings. Especially CHIP is considered when they exclude significant cytopenias, but there is evidence of clonal hematopoiesis. Well said, is when there is low counts, but there is evidence of one of the genes involved. ICOS is when there is unilinear or multilinear cytopenia, but there is no findings of gene impair and doesn't meet criteria of MDS. And as you can read in here in the slides, CICAS is a little bit more for multilinear cytopenia and clonal hematopoiesis, but still doesn't meet criteria of MDS, and MDS obviously when there is more than 10% changes of cellularity and characteristics previously reported in the WHO. Next slide, please. So with this said, we know that there are several markers who are adverse prognosis, especially the TP53, the XL1, and other ones can reflect adverse prognosis, as we can see on the red lines. However, if the SF3B1 is present, is the blue line, is one that express, better prognosis. Next slide, please. So what we approach, nowadays with MDS, one of the things that we have to base and undercounter is not what we see already with the immune component that is happening. Is what is the treatment option is going to be depending on the patient characteristics by the IPS score, meaning the lower risk and the high risk disease. And if the patient is in high risk disease, if the patient could be transplant candidate or not. So one of the things that are very important is as well in the lower risk category is the presence of the lesion 5Q, the erythropoietin level, the uses of lenalidomide or hypomethylation or other cytopenias that we can use, especially immunosuppression therapy that have been recently described in a combination with the checkpoint inhibitors by Dr. Garcia Manero, but also other therapies involving ATG and cyclosporine that have been all usage in the past. Next slide, please. So one of the things is the lower risk therapy that may encompass the use of growth factors or lenalidomide, especially speaking when the erythropoietin levels are below 100. And that can be a good response, especially talking about 74% in the case of the patients. In intermediate response, it's going to be 23. If it's, when we talk about 100 and 500, and when there is more than 500 in the erythropoietin and more than 2 transfusions per week, we're talking about poor response to the growth factor and lenalidomide. The next slide, please. So talking about that, it's important to know that Revlimid has been one of the important characteristics and treatments that have been reported previously by Dr. List. A transfusion independence is 2.2 years, and the treatment is 10 milligrams, as we know, 21 days. One other therapy that has been, and I describe it just briefly, is the use of ATG and cyclosporine. Especially this therapy is mostly used in patients who have hypocellular MDS and patients who have a little bit more in the presence of HLA-DR15 that probably they can respond, and younger patients too, that they can probably respond better to ATG and cyclosporine. Lenalidomide, an immunomodulator that it has been also reported, it can be having some partial responses as seen as well in patient non-deletion Q, especially in settings of low-grade disease. Next slide, please. So we can see a little bit more about the MDS-04, and we are talking about transfusion independence, which is the most important thing. This has been reported by Dr. Fenno. Next slide. For high-risk disease, the recent history is taking a difference because one of the most important studies was the ASA-001, who was reported by Sillerman and collaborators. It was the usage of 75 milligrams per meter square day 1 to 7 in Q28 days for 4 months, and they were evident to use by the hypomethylating agents or azacitidine, and they have been finding responses very well, known by us. This is the study of the CLGB 9221. Next slide, please. But we know that epigenetic markers, they can improve the overall survival, as we can see. However, complete responses have been still a little bit low, talking in total probably 60%, but there are several strategies that they are looking to improve this, and one was the combination therapies. This is probably one of the most important assets that we have to look, and there is recent approval of medications, including cedarurcin plus decitabine for MDS intermediate 1 and 2, that have been recently approved by the group of MD Anderson, who had collaborated very well in having the support of this medication approved by the FDA. And then later another medication that is going to be looking very promising is probably the CC486, which is the oral azacitidine as well. So, but the combinations are the most important thing, and Dr. Garcia Manero and collaborators have used, especially in trying to enhance the immune system, using the combination of Nivo or other checkpoint inhibitors. Next slide. So this is the novel approaches that we're going to be looking. Part of they have other characteristics that they are not much related to the immune system, but in somehow they have a good overview of what's happening in the myelodysplastic system. One is the usage of APR-246, and that is having good results, especially for P53 mutant patients, and this is led by Dr. Salman from Moffitt Cancer Center. As I told you about the checkpoint inhibition, the usage of pembrolizumab or nivolumab, especially for blocking PD-1 and PD-L1, the toll receptors from checkpoint, there is interest as well for other components. And one of the most interesting, besides, has been the recent approval of luspatercept, who has some TGF-beta blocking and produces, especially in patients who are lower risk disease, increase of the transfusion, decrease of the transfusion requirements that happens most of the time on this patient after failure of hypomethylating agents. The use of venetoclax is still limited to clinical trials, but look promising, especially in patients who are oligoblasts. Let's say, patients who have 10% or more blasts, and these studies are led by the team of MD Anderson with Dr. DiNardo. Next slide, please. So as I said, this is a novel approach from luspatercept that anemia is one of the hallmark of MDS that probably is in particular difficult to treat. There are some changes in maturation and ineffective hematopoiesis. But one of the things that happen is that there is excessive GDF-induced MAT3 that is an inflammatory marker signaling that inhibits the red cell maturation. So part of this ineffective erythropoiesis that is led by the SMAT3 encompasses, next slide please, signalings that are very good, especially the modified activator receptor 2B protein, which is the luspatercept, that ligands, for the GDF11 and other family member ligands from the TGF-beta suppress this SMAT3 signaling, increasing the hemoglobin, especially has been seen early in patients who were healthy donors or healthy volunteers. However, in patients who were having problems, especially in MDS, and the next slide, and you can see that it was limited to patients who were having SF3B1 mutant. Next slide, please. So part of this, the Medalist trial had been a phase 3 that it was encompassing 229 patients, and the randomization was 2-to-1. It looks very promising, especially in healthy volunteers, as I said, but the characteristics was probably to start thinking about patients with low intermediate risk with ring sideroblasts. What I said ring sideroblasts is because SF3B1 is most characterized in patients with these characteristics, and the dose had been 1 milligram or 1.75 milligrams. Next slide, please. And these had been already able to show characteristics very significant in patients. One of the most important things signally was, yes, initially, as I said, and it's very repetitive, so this study is the responses that it has been seen in ring sideroblasts. We're talking especially the presence of S3B1. Patients who were refractory for EPO was one of the characteristics, or erythropoietin, and having more than 6 units, they would really respond very well as well. But as you can see in the red lines, underlying S3B1 mutant were the higher responders. We're talking about 92 versus 85 in the placebo arm. Next slide, please. So pretty much this is something that we were looking. Luspatercept compared to the placebo doses from 1 to 175 milligrams per kilo, they were able to show responses very well. Next slide, please. And we're looking into responses early as 8 weeks, transfusion independence, and week 24 to 25, the markers were very significant speaking, talking about p-values less than 0.0001. Next slide. So part of this, as I said, the sub-analysis was very good. It shown the subgroup analysis that patients who were having more than 6 units, they were responsive as well. And also, they were talking about baseline platelets, and it was very good. Next slide. One of the important things to say and to involve is that, yes, certainly luspatercept compared to placebo was showing improvement, transfusion independence more than 12 weeks. Next slide, please. And the characteristic of adverse event, it was barely comparable to placebo. It was a little bit of fatigue, mild diarrhea, that it has been described compared to placebo. Otherwise, it was excellent tolerated, this medication compound. Next slide. So the conclusion is that 37.9% of the RBCs transfusion independent was happening more than 8 weeks after treatment compared to placebo. And they achieved the secondary endpoints of this trial comparing to placebo. It was well tolerated and arising as a new drug that led to the FDA to be approved, and we have this medication approved. It's very important to highlight, yes, because SMAD and the other receptors are very expressed, especially in patients who have immune characteristics. Next slide. Other compounds, we're talking about wandecitabine, that is a next generation hypomethylating agent that is probably used at this point in MDS and CMML, especially in patients who are treatment naive, and this was done by Dr. Garcia Manero from MD Anderson, or also in relapse refractory patients. We're talking about 53 patients. They were using 60 milligrams day 1 to 5 and compared to 90 milligrams per meter square in day 1 to 5. Next slide. And the results have been very satisfactory, with a median follow-up of 3.2 years, with a median follow-up of 5 cycles. MDS treatment naive, the responses were 22%, overall responses 37%. Relapse refractory MDS responses were 4%, with overall responses of 32%, with a median duration of 7.9. Just to highlight, in relapse refractory patients, the population is very, very difficult to treat after usage of hypomethylation agent frontline. So this is something that we are looking and is looking optimistically well. And as Astral study is already ongoing for relapse refractory versus MDS and doctor choice. Next slide. So in previously untreated patients, the responses, as I said, were CR22, overall responses 61, with overall survival of 15 months. It seems better than the previous first generation, apparently, but more studies are doing and they're currently being conducted. Next slide. Just to give a wrap-up of what actually happened before we abandon this usage of the hypomethylating agent, it's very important to say that a patient that we recall that he got therapy with hypomethylating agent, he was able to conceive a good and lasting response. However, the epigenetic markers were able to assist in improving his symptomatology of the dermatomyositis partially. However, after a stem cell transplantation happened, the patient fully recovered. So this is an important thing that happens especially with the immune system when it's switched for a transplantation process. Going back to the slides, in the Telesto study was another thing that is very important in low-risk patients and is especially very important for transfusion and iron overload. Next slide. I just wanted to mention that there were 225 patients, and basically the characteristic was that they were 149/76, and the response especially was very significant. We're talking about overall survival, that it was better comparing deferofirox with placebo. And one of the things that it was important, as I said, it was to improve the event-free survival. Cardiac, liver, and AML transformation was significantly impacted using deferofirox, especially in patients with lower risk disease. Next slide, please. But one of the things that we noticed as well on the previous slides, talking about the immune component, it was the presence of caspase as well as stimulation. This is probably one of the things that happen as well when eventually the disease is progressing and getting from oligoblast to acute myeloid leukemia. And the group led by Dr. DiNardo from MD Anderson was able to use these BH3 activators or anti-apoptotic medication like calling venetoclax to inhibit the BCL2 and led to a death signal, which was very comparable to get complete responses from patients who were AML. So next slide, please. The inactivation led, and this is the phase 2 study that was using for acute myeloid leukemia patients. Initially, single therapy, monotherapy was not able to achieve more responses than more than 19%, but significantly and has grade 3 to 4 febrile neutropenia, which is probably one of the things that it was going to be the limit, and especially in patients with MDS. However, these studies are probably phase 1 and 2 at this point, and MD Anderson, and they're looking very good. The most important thing is in the cytogenetics and the molecular level is that IDH inhibitors 1 and 2, probably they are very good control, especially NPN1 monitoring is very good as well for inhibiting, and the other component, FLT3 ITD, there were no responses at all. Next slide. So these are other studies that are showing the same situation in combination with low-dose RC that it was led by the group of Dr. Wei in Australia. As you can see here down in the diagram, you can see that the complete responses were very favorable when there is combination therapies, but this is just in case in patients with AML. Next slide. And this is a phase 1b that it was done with Dacogen and Bidase. For 4 courses, complete responses were significantly. I'm not getting more details on this because it's AML, but this is just extrapolating the disease on oligoblasts or patients who have from 10% to 20%. Next slide. Several other the combinations with HMA, complete responses were significantly in patients with AML. Next slide. And in particularly, this is what actually they're doing. Decitabine 10 days in AML or high-risk MDS, in patients with newly diagnosed AML, they were showing 50% of complete responses. In relapse refractory was 16%, and in patients with AML, they were having significant response if they were newly diagnosed. Patients with relapse refractory disease is very seldom they get responses with this therapy. So, but they're going from 5 days to 10 days. They look like there is no much difference. However, this is something that is being explored in Houston. Next slide. The other is another study that they're doing, especially the IDH1 and IDH2, which is very prevalent, well, rarely prevalent in AML, talking about 15 to 8%, as you can see here in the slide. In MDS, it's a little bit smaller as well, the quantification, but there are inhibitors there. The minimal GI toxicity is happening with enacidonib or ivosidenib, and the responses are close to 16%, but this is data that we are extrapolating from AML. Next slide, please. So, yes, one inhibitor, the IDH1 or the IDH2, the ivosidenib, treated in patients with AML and MDS as well. 21 received one cycle of, this is the oral pill, and 11 patients received the maintenance therapy after consolidation, or some patients proceed to hematopoietic stem cell transplantation. In these patients with either enacidonib as well, the response super significantly, but this is AML as well. We are thinking that MD Anderson is going to probably use this combination or this medication probably in MDS, and there are some studies conducted at Memorial Sloan Kettering and MD Anderson too. Next slide. But the most important thing as well, is immunotherapy. And this is probably going to be the highlight, for the subsequently years. So we talk about IDH inhibitors. We didn't mention much, but it's going to be very important to talk about the CAR-Ts. And that is very evolving territory. And there is no such, for AML at this point. But there are some components that we may probably be looking into the near future. We're talking about anti-CD45, that are radio-labeled combinations that they've been using in AML, the anti-CD33 combinations and BiTEs, which is a molecule that is a double combination of CD3 and FLT3 sometimes, inhibitors too, and some others that maybe they can affect the NK cells, the T cells, and so on. These are here in the slides for you to read, but they are in clinical trials at this point. Next slide. But as we are mentioning, one of the things that was happening and is currently one of the important things is when to transplant a patient. One of the things that is very important is to mention that patients who are low risk, despite the fact of having subsequently problems, they're going to be not really immediate transplantation. Is not going to be improving the overall survival as much in patients who are low risk. As you can see, intermediate 1 transplant immediately or in 2 years, the survival is probably similar, as you can see in the diagram that is in here. However, in patients with high-risk disease, and this is one of the most important thing that we have to understand, patients who are high-risk disease is not only the patients who are evidently looking with high blast number, it's also with patients who have really aggressive conditions like molecular markers and so on, talking about immunomodulation and so too. This is a territory that we are still understanding, that patients may probably have to go for a stem cell transplantation to improve their outcome a little bit earlier. So talking with that, I will have to go to the conclusions. Next slide, please. So one of the things that we have to understand is that we are beginning to learn how to combine the target therapies and the approved therapy that we have, especially the hypomethylating agents. In immune system, we know that the use of ATG and cyclosporine is very limited. The usage of the TGF-beta inhibitors like luspatercept have opened a territory that is very good for exploring at this point, especially blocking the SMAD2, 3, and other ones is going to be something that is going to come up on the future years. Immune-based therapy is something that we are looking and is beginning to advance, especially with the introduction of bispecific markers, as I was describing on some of the slides. However, checkpoint inhibitors is something that we still have to look and to compare, because especially in patients who are refractory to hypomethyl agents, there are not novel therapies that we can use at this point. And the use of antibodies, especially the biospecific antibodies, may play a role specifically for FLT3, toll-like receptors, or some others, TNF-beta or so, that it can improve, the outcomes. I didn't get into much details of this, but basically the immune system and the immune-based strategies are something that we are looking, especially with the CAR T therapy as well, and it's something to consider for the near future. Next slide. So with that, I really would like to thank, the audience for listening to me today. And if there is any question, please don't hesitate. I will be more than happy to answer them all. Thank you so much.
Thank you so much for the wonderful presentation. We do have a few questions. What is the connection between autoimmune disorders and MDS?
Excellent question. So far, probably is in use of the cytokine or the interleukins that they are connected to the myeloid-derived stem cell progenitors, that they are affecting in a little bit the development of normal cells. They create a nasty environment, especially on the cells to grow satisfactorily, and specifically in low-risk patients, this environment may traduce into more transfusions.
Thank you. Are there specific autoimmune disorders that are most commonly connected to MDS?
So we are starting to explore. Dr. Conroy from Moffitt Cancer Center, he was looking into some of them, but it's not specifically described at this point. There are more incidents of hypothyroidism, idiopathic thrombocytopenia, rheumatoid arthritis, and psoriasis as well. I just exposed a case of a vasculitis that it was present, or a dermatomyositis too. It's very important to not to link, but probably to consider the importance of having this as a reflection of something that is already ongoing on the MDS scenario.
Does the combination of an autoimmune disorder and MDS, does it impact treatment and treatment outcomes?
Correct. That's a very good question. So unfortunately, the data is very scant. We're talking about multiple retrospective information that is happening, and some of them, they are conflictive. Some of them, they say that the odds of having an autoimmune disorder and MDS may impact in the overall survival. I will say that this, until we don't have more information, it is not particularly say so. In my personal experience, it had precluded to manage the patient with hypomethylating agents a little bit earlier, and to bridge to stem cell transplantation, but it will not impact in the overall survival per se.
Thank you. Our next question is, any relation of LLGL or STAT3 mutation to MDS?
Yes. So the first diagram that it was showing some relation of LGL with STAT3 mutation and MDS, there is some overlapping syndromes. Sometimes it's very difficult to treat LGL, in particularly when they are having significant characteristics in the bone marrow that may preclude that there are some similarities with MDS. In essence, I will say that yes, there is particularly some overlap, but still there are two entities that they can be treated separately. If it's a little bit more MDS looking picture, probably we have to use hypomethylating agents. If it's more LGL, probably we can use other therapies like methotrexate, cyclosporine, or Cytoxan as well that have been linked to good responses. So there is some overlap. I feel there is, and there is for sure, but therapies at this point, they are a little bit quite different.
Thank you. Our next question is, Dacogen treatments wipe out blast, do Dacogen treatments, wipe out blasts as well as cancerous bone marrow stem cells?
Yes, so Dacogen is a very good hypomethylating agent. Decitabine for sure is one of the medications that we use to wipe out the blast, but it takes a little bit long in order to get responses. We are talking about probably 3-4 cycles therapies in order to do that. Sometimes it's a little bit more, 6 cycles, and before calling that this a failure. It really does knock down by the CPGI islands in the DNA scriptures, but it doesn't affect the stem cell progenitors, no. It is something that is modified and trying to grow particularly different. So in summary, I will say that the Dacogen may affect the blast percentage, yes, but it doesn't affect at the point that inhibit the cells for sure, yes.
Thank you. If Dacogen becomes less effective over time, what other treatment options are available?
Excellent question. So first of all, we have to consider that the responses are not really good and that conventional therapy, probably rotating from Vidasa or azacitidine to Dacogen, which will be one of the strategies that it had been commonly used in the past. We're talking about the order of 20% as much of complete responses in patients who are one hypomethylation failure. However, there is novel therapies that we are using in case of this circumstance. There is one product, it's called cedurocin, Dacogen cedurocin, which is oral. It's called Incovi. And basically this combination, oral chemotherapy, gives good highlights of probably getting better responses in the near future. This study was led by Dr. Garcia Manero, and the medication is not available yet in the market, but is FDA approved. So probably that's something that we can do for the future.
Thank you. Is there a higher rate of relapse following transplant in patients with an autoimmune disorder?
Based on the retrospective data, it doesn't look like that much picture, although the data is very scant in the literature. I will say that we have to keep alert because the immune system may have been switched when there is a stem cell transplantation, but from the literature, I will say it's probably comparable.
Thank you. Our next question reads, there are strong anti-inflammatory meds used for COVID-19 cytokine storm. Would these meds be of use in managing MDS patients either before or after transplant?
Is another perfect question and well to consider. One of the cytokine medication that we use is tocilizumab. This is for cytokine storm, and that it happens in COVID patients as well as patients that receive the CAR T cell therapy. This is something that we are looking. So far, by personal experience, we use another similar medication called the AXL inhibitor. That is very good as well for modifying that, and it has been looking promising for COVID too. The responses are disparate, unfortunately. Probably we have to understand a little bit more of the science ourselves. We have to understand about the science and the application. But I don't think, it's probably capable to use that in MDS yet. Saying so, I don't discard the use of other, in the interim, of the mechanisms that are happening in the stem cell, but not currently the medication that are available.
Thank you. Is ITP considered an autoimmune disorder?
Yes, idiopathic thrombocytopenia purpura, ITP, is considered an autoimmune disorder. The report from Dr. Conroy, they were reporting that 48 cases, or 12% of what he found, it was actually patients who were having MDS or patients who have ITP and later were found to have MDS.
Thank you. Our next question comes from a patient who just received their 5th injection of luspatercept. They've had little response to the treatment. Is there a time frame that patients should see a response?
Yes, and that's an excellent concern. So far, what we have seen in here is that basically at 24 weeks or so, we have to probably look into good response and the ultimate margin. If he is F3B1 positive, that's another characteristic to look to. If he wasn't, probably he's not going to respond very likely.
Thank you. Our next question is regarding the recent approval of Oncology. Is it possible for patients to switch from Dacogen to the new oral medication Oncology?
That's something that is happening a lot. Questions about this is coming on now with a new approval. I will have to say that if it's working, we just leave the strategy that works to continue. Saying so, if you are on Dacogen or decitabine or azacitidine, I will just keep on the same medication to continue and leave the oral combination in case the patient relapses or not. Not to switch if it's already working. If it's not working, I think it's time to switch.
Okay. Well, that's all the questions that we have for today. So thank you so much for your wonderful presentation and sharing your time and expertise with all of us. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please feel free to submit them to us at any time in 3 ways. Send an email to help, HELP, at aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program.